In the 1940s, Walter Cannon, a pioneering physiologist known for his work in the fight-or-flight response, introduced a chilling concept, voodoo death, a phenomenon where sheer fear, anxiety, and mental distress can lead to physical and mental effects, including death. Today, we see a similar haunting effect described as PTSD, a neuropsychiatric condition experienced by someone being exposed to traumatic events. It is a disorder of fear dysregulation, where flashbacks, overwhelming emotions, and intrusive thoughts can cause disruption to daily life. For some people, seeing a campfire can evoke traumatic memories of being trapped inside a burning house.
Let's take a look at brain circuitry. In PTSD, there is an imbalance between the prefrontal cortex and amygdala. The PFC, which is responsible for stress and emotion regulation, becomes underactive, where the amygdala, the brain's fear center, becomes overactive, causing a constant feeling of threat. This constant feeling of threat puts individuals in stress, leading to excessive release of glutamate, overstimulating AMPA and MDA receptors, increasing calcium intracellular level, ultimately leading to cell death, disrupting the long-term potentiation in hippocampus and amygdala. Consequently, PTSD sufferers experiencing cognitive impairments such as difficulties with attention, memory, and emotional regulation, which reinforce trauma cycles and heightened fear.
PTSD is commonly treated with selective serotonin reuptake inhibitors, SSRIs, and psychotherapy. SSRIs work by inhibiting serotonin reuptake in the synaptic cleft, which increases the amount of serotonin available for neurotransmission in the brain. This increased serotonin acts through a process known as volume transmission, where it diffuses broadly rather than targeting specific neurons to influence larger brain areas and help maintain a balance of excitatory and inhibitory signals. During traumatic stress, serotonin release in areas like the prefrontal cortex helps reduce anxiety. However, chronic stress, as seen in PTSD, can deplete serotonin levels, weakening the brain's ability to manage emotional responses and lead to symptoms like irritability. Despite their widespread use, SSRIs are not effective for everyone. 35 to 40% of individuals with PTSD do not respond, highlighting the need for alternative treatment options.
Psychotherapy targets the brain's threat extinction circuitry, primarily focusing on activating the PFC to help patients regulate emotions and unlearn their fears. But the path to healing is not easy. Psychotherapy for PTSD has a long dropout rate, and for many, it doesn't yield the life-changing result they need. So, where does this leave us? Many are left searching for more effective treatments.
3,4-methylene-dioxymethamphetamine, also known as MDMA, was originally developed in the early 1900s as a base compound for synthesizing other pharmaceuticals. Known for its euphoric effect, MDMA later gained popularity as a recreational drug, ultimately leading to its FDA ban in 1985. Despite this reputation, recent research has demonstrated MDMA's ability to enhance the effectiveness of psychotherapy for individuals with moderate to severe PTSD.
MDMA targets presynaptic serotonin transporters, releasing a burst of serotonin into the brain. Through this enhanced serotonin, MDMA induces a positive emotional state and prosocial behaviors in participants, providing a safe and supportive setting that allows them to face emotionally challenging experiences without overwhelming discomfort. This feeling of safety was demonstrated through effective psychotherapy studies to be necessary for traumatic memories to be recalled with less fear. Moreover, this increase in serotonin augments oxytocin release, which reduces neural threats processing, calming the overactive amygdala and facilitating fear extinction, learning, and retention. Essentially, it creates a unique state that enables patients to engage more openly and effectively in therapy, reducing the likelihood of participants dropping out of the therapy session altogether.
MDMA is considered as a dirty drug because it binds to multiple targets in the body. Acting as an agonist at alpha and beta adrenergic receptors, MDMA can cause acute surge in blood pressure and heart rate, potentially putting individuals with heart conditions at risk. After MDMA use, the serotonin surge can lead to a post-MDMA crash, causing serotonin depletion and symptoms like emotional sensitivity, brain fog, and difficulty concentrating during the crash period. MDMA also affects dopamine and noradrenaline transporters, heightening stimulation and euphoria. But it also increases cardiovascular pressure, and repeated high doses can potentially lead to neurotoxic effects. MDMA's interaction with multiple receptors highlights the need for careful clinical oversight in therapy sessions. PTSD is a complex and deeply distressing disorder. MDMA-assisted therapy offers a potential alternative by addressing the brain's fear response in a safe, supportive environment. While this approach may lead to breakthroughs in PTSD treatment, it also carries risks and requires further research to enhance safety and deepen our understanding.